This is Dr. Burns. Thank you for joining me in this video where I'll be talking about the assessment, diagnosis, and treatment of developmental trauma, complex PTSD, and dissociation. I know that this lecture looks long, and yet at the same time, every minute of it is important for you to hear so that you will understand by the end of the video why I am making the recommendations that I am actually making. So again, this is critically important information, and I appreciate the time and effort that you're taking to learn more about it. So how is it in 2026 that the medical and mental health professions to this day still do such a pathetic job at helping individuals who suffer from trauma in any meaningful way, and especially those who have either suffered from childhood trauma or more than one traumatic experience? Certainly, a litany of humans have contributed to this, and disgustingly, their damaging legacy continues to this day. So we're going to have to start at the beginning. We now know that if an individual has experienced repeated, especially childhood traumas, they will very likely suffer from some form of dissociation as well as complex trauma reactions. Let's also be really clear that everybody has parts. Some people have parts that are afraid of public speaking, others have parts that are afraid of heights. Some have one part of themselves wanting to quit a job while another part wants them to stay. While not called this at the time, the first, at least fairly well documented case of what we now call dissociative identity disorder, DID, was in 1584. Jean Ferret had suffered from childhood physical and possibly sexual abuse. She and her exorcist recorded in detail her symptoms, which exactly match those that are found in today's DID diagnosis. She had multiple parts, each with her own name, identity, identifying features and roles, such as an internal self-helper, persecutory prosecutors, and child parts. Her parts were associated with actions that range from helping her to heal, to inflicting self-harm, and even disordered eating. These different parts could allow for various actions, conversion features, and changes in knowledge and skills to occur. Benedetta Carlini was born the 20th of January 1590 near Florence as an only child. Her parents had shown signs of dissociation and had been rumored to be possessed. In 1599, after her father's death, 9-year-old Benedetta was left at a semi-monastic community because her symptoms had become uncontrollable. She eventually went on to become Sister Benedetta, who suffered from self-harm and disordered eating. By 1623, Sister Benedetta was possessed by 3 angelic boys who would beat her to cause chronic pain. One of her angels was frozen at age 9, the same age at which Sister Benedetta's father had died. When they took control of her body, each would speak with a different dialect and tone of voice while using different facial expressions. Benedetta had amnesia for some of their actions, including a sexual relationship that they had initiated. So you can see early on that DID had a history of being associated with possession. After the public view of possession was no longer socially acceptable, those with DID were seen as hysterics. The Greek word for uterus, hysteria, was defined as a disease of ungovernable emotional excess, nervousness, and hallucinations that was only experienced by women. Hysteria was seen as primarily dissociative in nature and could involve disturbances of memory, consciousness, affect, identity, and bodily functions, which are the same symptoms today associated with dissociative disorders and particularly with dissociative identity disorder. Now, while most of the time those symptoms were only diagnosed as hysteria for women, Louis Vivet in 1882 was actually the first person to be officially diagnosed with multiple personality. He was physically abused and neglected as a child and had frequent attacks of hysteria. One such attack occurred when he was 17 and bitten by a snake. He lost the use of his legs for almost 1 year, and when the use returned after a 50-hour hysteria attack, he didn't remember any of the physicians who had been treating him in an asylum for the last month or any of his fellow patients. His manner, morals, and appetite were different as well. Following additional attacks the next year, his character would change from impulsive and dangerous to calm and gentle. Then, in 1884, he had another hysteria attack, and that left him gentle of manner but unable to walk. And then a completely different attack returned the use of his legs, but it left him quarrelsome and inclined to steal as he had done as a child in order to survive. He also had a lot of amnesia. By 1888, he had been recorded as having 10 different personality states, each of which were different in character, memory, and body symptoms. Clara Fowler was born in Beverly, Massachusetts on the 20th of January, 1873. Her father had a violent temper, her parents were unhappily married, and her mother made it clear that she disliked her daughter. Clara's first disassociation produced the first split-off part, which coincided with the death of her 4 days-old brother Charles on the 7th of June, 1880, when she was 7. Another newborn sibling, Bessie, died when she was 13, and she blamed herself for the death of a newborn sister. Later the same year, her mother died of a terminal disease, which Clara felt was her fault. A series of emotional traumas over the next 3 years, which were attributed to likely severe abuse by her father, caused her to flee her home permanently at 16. In 1898, at the age of 23, she came to Dr. Morton Prince seeking relief from physical symptoms that included headaches, body pains, insomnia, and exhaustion. At this time, she had become too weak to continue her work as a nurse in a children's home and hospital. She was studying at a New England college where she was well regarded as a bright and diligent student by teachers and friends, and said to be an avid reader. However, they had now begun to notice her swift changes in mood and character. Prince found her to be refined, well-educated, well-read, highly conscientious, restless, sometimes lost in abstractions or fixed ideas, inclined to bear ill treatment in silence, and sometimes unable to do what she wished. She was reluctant to discuss herself or her circumstances, even the symptoms for which she sought treatment. He began using hypnotic suggestions to ease her pain, which produced an entirely different part. This part was vivacious, bold, and assertive, and talked like a rebellious child, resisting all efforts to control her. She also exhibited hostile feelings about the real Clara, calling her stupid and complaining that she went around with her head in a book. In this state, she was numb, unable to even feel pricks or burns. Her eyes were closed, and she continually rubbed them, complaining it was unfair that the other part could see and she could not. Once this hypnotized part was brought forward by Dr. Prince, that part began tormenting Clara by leaving abusive letters for her to read after Clara regained control, forced Clara to tell lies, tore up her homework, unraveled her knitting, and arranged visits that Clara would have to then honor. No efforts by Dr. Prince were able to stop any of this. On the 7th of June of 1899, Clara asked Prince to come to her home. At first she was unable to speak for nervousness, but then suddenly changed. She chatted pleasantly and seemed healthy-minded. However, she now insisted that Prince was not Prince, but her friend William Jones, and that he had entered through a window. Prince realized that he was witnessing the birth of a completely new part. This third part had memories of life until Clara's age of 20, but the next 6 years were missing. However, the third part attempted to conceal this, gradually learning incidents in that 6-year period from Prince and other people. She was not aware of the other two parts and was angry at being spoken to familiarly by people to her or strangers. Because she seemed healthier in mind than Clara, Prince wondered if she might be the true part. However, the third part tended to be angry and selfish. Now haunted by two other parts, one of whom was free spending, Clara got a job as a waitress but was unable to sustain it due to the antics of the other two parts. She attempted suicide by closing the windows and turning on the gas, and this was only prevented by the emergence of one of the other parts who turned the gas off. In the spring of 1901, Prince attempted to reintegrate the parts. This intensified their war against each other. And then in January of 1902, during hypnosis, one of the parts was told to awaken with all of Clara's memories intact. After that, Clara was supposedly physically well, enjoyed peaceful sleep, was without hallucinations, impulses, obsessions, and abnormal suggestibility. Prince's case report concludes with a description of a 6-month period when Clara was integrated and in control, with only one part that would reemerge in times of stress. So now we come to the topic of Freud. At first, Freud uncovered the truth. Freud treated hysterical women by talking to them and concluded that psychological trauma and a supposed hereditary predisposition was what caused hysteria. He created his seduction theory in the mid-1890s. The hypothesis was that repressed memories of early childhood sexual abuse were the essential precondition for the development of hysteria and obsessional neuroses. Freud had actually started off as a supporter of those experiencing childhood traumas, initially working on the effects of trauma and bringing to light the sexual abuse that went on in families. At the time, he believed that sexual abuse in childhood was responsible for many of his patients' neuroses and other mental health problems, and Freud was the first psychiatrist to believe his patients were telling the truth. His early papers in the 1890s embraced the mechanism of dissociation, and he gave a speech called The Etiology of Hysteria in April of 1896, where he claimed that all 18 of his patients had experienced sexual assaults by caretakers, with the abuse often occurring before the age of 4. He describes these experiences using terms like rape, abuse, and attack, emphasizing the violence and power imbalance involved, and believed that such trauma created unconscious memories incompatible with the individual's sense of self, leading to psychopathology. At the time, Freud strongly believed his seduction theory and wrote in letters to close friends about the autopsies where he'd seen something of which medical science preferred to take no notice, that of the bodies of children that had been raped and murdered. In 1897, Freud carried out a self-analysis, making himself his 19th patient. He concluded that he and his siblings all showed the same symptoms of hysteria, which implied that they too had experienced sexual abuse as a child. Unfortunately, Freud's colleagues maintained that a child's report of sexual abuse was a symptom of a pathological fiction or fantasy by the child. They were appalled at Freud's ideas, and choosing to save his career and reputation, Freud chose to follow suit in dismissing victims' claims. This is what prompted him to introduce the Oedipus complex and penis envy as an explanation for female patients fantasizing about their rape. He then suddenly concluded that the memories of abuse were not literal, but were unconscious fantasies. This shift led to that development of many later theories and the concept of psychical reality, where the emotional impact of an imagined experience could be as significant as an actual one. In his desperate attempt to salvage his career after the speech in 1896 and gain popularity, Freud normalized the despicable practice of adults initiating children into sex and paved the way for not only a major setback to treating repeated childhood trauma, but also the field of psychology for years to come. So, for example, during his 1900 study of a patient called Dora, she had alleged that she had been molested as a child by a family friend, only to have Freud dismiss her claims and suggest that she imagined the advances. Florence Rush, in her 1980 book called The Best Kept Secret, wrote that Freud clearly avoided blaming fathers at this time at all costs. In his cases from this point forward, the abusers were sisters, brothers, aunts, and uncles, and even governesses, but never fathers, even going as far as to incorrectly publish an article blaming a 14-year-old's uncle as the one who molested her, but revealing decades later that it was in fact her father. It is also believed that Freud's decision to give up his seduction theory and to change to the Oedipus complex was influenced by abusers he knew personally. One of his closest friends, Fleiss, was suspected of having molested his own son. Freud would often confide in Fleiss, sending him letters discussing how he believed that hysteria or psychological disturbances were a result of sexual abuse. Upon realizing that Fleiss himself was guilty of such abuse, Freud gave up his theory and evidence. Other theories as to why Freud abandoned his initial claims range from denial of his own personal experiences to protect his own family, to the knowledge that in a society where so many influential people were abusers, his claims would go unheard. His decision was later called a failure of courage rather than a clinical or theoretical insight by psychoanalyst Jeffrey Mason. Freud introduced the Oedipus complex in his 1899 work, The Interpretation of Dreams, drawing a parallel with the Greek myth of Oedipus, who unknowingly kills his father and marries his mother. The Oedipus complex describes a child's unconscious sexual desire for the opposite sex parent and feelings of rivalry or hostility toward the same sex parent. According to Freud, a boy develops an unconscious desire to possess his mother and replace his father, whom he views as a rival. This leads to castration anxiety, the fear that the father will punish him by castrating him for these desires. Freud believed it could lead to pedophilia if not resolved in time. Freud also proposed a female counterpart to the Oedipus complex known as the Electra complex, where a girl develops unconscious desire for her father and hostility towards her mother. This is where Freud introduced the concept of penis envy, suggesting that girls feel resentment toward their mothers for not having a penis, which he believed led to a weaker superego and less developed female identity. Sadly, Freud also believed that women's lives were dominated by sexual reproductive functions and that they were simply men without penises. Freud claimed that the only way they could overcome this penis envy was to have a child of their own, even going so far as to suggest that they wanted a male child in their efforts to gain a penis. His theory was unfairly based on a model where there was no place for femininity unless directly related to masculinity. Women were viewed as forever feeling morally inferior to men, who were said to have more developed superegos than women. This, according to Freud, was a problem that females could never resolve. In 1925, Freud wrote in The Psychical Consequences of the Autonomic Distinction Between the Sexes that women oppose change, receive passively, and add nothing of their own. Helen Deutsch, a student of Freud's who was the first female allowed into Freud's Vienna Psychoanalytic Society in 1918, published the first psychoanalytic book on women's sexuality in 1925, stating that women had a passive masochistic sexuality and were born only for reproduction. Her book said that a young girl's lack of a penis meant she stopped identifying with her father and went on to develop fantasies of being raped, which was an integral part of female sexuality. Thus, the idea of a woman's personality being determined by her lack of a penis was strongly reinforced in society. Freud's concept of penis envy was criticized during this time by psychoanalyst Karen Horney. She introduced the idea that men were affected by their inability to bear children, calling it womb envy. She explained that men felt envious of the biological functions of the female sex, like breastfeeding and pregnancy, calling it male striving for achievement as overcompensation. Horney reasoned that Freud's theory of penis envy made more sense when it was taken as a metaphor. Penis envy was a symbolic longing for the social prestige and position that men experience. Thus, women felt inferior because of the freedom and social status that they lacked because of their gender, not because of their literal lack of a penis. Freud responded to her writing, and I quote, "We shall not be very greatly surprised if a woman analyst who has not been sufficiently convinced of the intensity of her own wish for a penis also fails to attach proper importance to that factor in her patients, end quote. According to Freud, Horney's development of the concept of womb envy was rooted in the penis envy she herself experienced. 50 years after Freud, Jessica Benjamin released A Desire of One's Own in 1986, where she wrote of how the Oedipus complex only encouraged the patriarchal hierarchy. She further wrote on how penis envy was not because of lack of a phallus, as Freud described, but because of socio-cultural reasons, making it an irrelevant part of female sexuality. Horney and Benjamin's take on penis envy perhaps makes a lot more sense than Freud's ideas. As proposed by Clara Thompson in a 1943 paper, social envy, a sociological response to female subordination under patriarchy, is much more suitable. So it's understandable how women might feel envious of the power and prestige men have in most societies around the world. From sexualized comments on the street to even the current wage gap, men still tend to be in positions of dominance. But back in his day, a large number of psychologists spoke out against Freud, but the concept of penis envy had been created and the damage was done. Freud and his theories were accepted and set back our understanding of child abuse. Victorian men of his time were thus able to hide their illegal and immoral sex practices as long as the surface of Victorian respectability was in no way disturbed. Any attempt to expose the violator only exposed the victim's supposed rape fantasies, stigmatizing them further so that the only thing they could do was remain silent. It wasn't until Sandor Ferenczi's 1932 Confusion of Tongues that dissociation and subsequent splitting of the personality were explicitly linked to childhood trauma. His ideas, which anticipated our current modern trauma theory, emphasized the impact of childhood abuse and the importance of the counselor's active relational role, have been reevaluated and are now regarded as foundational to contemporary psychoanalytic thought in terms of trauma. At the time, the paper was met with strong opposition from Freud and his colleagues, with Freud actively campaigning against its publication in the English language International Journal of Psychoanalysis. The paper wasn't even published in English at all until 1949, and for the most part, Ferenczi's ideas were largely ignored. Now, also during this time, in terms of diagnoses, remember that the term multiple personality as a diagnosis was used for the first time in 1882. In 1910, Bleuler had introduced the term schizophrenia, and by 1927, the reported number of cases for schizophrenia rose dramatically, matched by a decrease in the diagnosis of multiple personality. One reason for this is that the original description of schizophrenia actually included multiple personalities. So many of those diagnosed and treated as having schizophrenia back in those days should have been diagnosed as having multiple personality. But because schizophrenia at the time was more popular, that's what they diagnosed. And so as such, the schizophrenia diagnosis around the turn of the century dominated over a multiple personality diagnosis. It's also important to keep in mind that in 1918, the diagnosis hysterical psychoneuroses was part of a subgroup of psychoneuroses and neuroses that included alternate states of consciousness acting on normally unknown desires, amnesia, and sensory and motor disturbances in the Statistical Manual for the Use of Institutions for the Insane, which was the predecessor for the DSM. And so at the time, this placed what we would now call dissociative identity disorder under a hysteria label. As we move forward, that bit of information will prove critical. Christine Costner Sizemore was born April 4th, 1927 in South Carolina. Her earliest memory at 10 months old is of the funeral of a 5-month-old cousin. She wrote of her fear of the white casket, her aunt's mourning, her father closing the casket lid, and her concern that her cousin might be scared of the dark, alluding to her own fears of darkness and death. She later describes in her book her guilt about still being alive when her cousin could not be. Christine witnessed at age 2 three traumatic events. The first is of a drunken old man who had died in a water-filled ditch and was retrieved by her uncle and father. She described the old man's decomposition and being scolded by her mother for having witnessed this. In the second event, Christine was again scolded by her mother, this time for sitting under her legs. As Christine's mother was churning milk, the glass jar breaks unexpectedly, and the mother presses the shards to her body to prevent Christine from being cut. Christine observes in horror as her mother's arm is slashed and is too paralyzed with fear to get aid for her mother. The final event was an incident that occurred at the sawmill where her father worked. When Christine's mother hears the whistle that indicates an accident at the mill, she and Christine go down to the mill and witness the dismemberment of a worker. Following these incidents, Christine is chronically and intensely worried about potential illnesses and/or death of her family members and loved ones. She said in her book, "It began when I was 2 years old, although I really didn't know I was different then. It wasn't until I began at school when I talked about the other little girls seeing things that I realized I was different." The other little girls were part of Christine's personality who would surface occasionally. Christine's dominant personality, which she assumed most of the time, had no recollection of the other girls' actions. Often Christine would become upset when she was accused of doing something that she could not remember having done. She said in her book, "Everyone thought I was lying. Of course they had seen my body commit the act. When I said the other little girls did it, they would laugh at me. Children are astute about these kinds of things, and after a while I stopped talking about it. I became a loner." At different points throughout her childhood, she was treated by her family physician because she complained of memory lapses. "He said I had a strange sort of amnesia," she said. She received no psychiatric help until at age 24, the personality called Eve Black tried to choke Christine's then 2-year-old daughter, Taffy. Apparently, the dominant personality in Christine came out and stopped Eve Black from killing the child. She said, "I feel terribly guilty about what happened to Taffy. I felt my daughter would be in danger if I didn't get help." Her psychiatrists at that time, Corbett, Thigpen, and Hervey McClelkey, first thought she suffered from atypical schizophrenia, which was how many multiple personality disorder patients were first diagnosed at the time, which we've already previously talked about. They admitted Christine to a hospital and recommended electroconvulsive shock therapy. At that point, the Eve Black personality emerged again and said, "There's no way you're electrocuting me." She packed her belongings and left. But the doctors continued to treat Christine using hypnosis and other supposedly less invasive methods than shock therapy. They thought they had cured her when the Jane Doe personality emerged. Jane Doe was an extremely strong-willed, competent, and loving person. But sadly, examples of unethical behavior by her treatment providers are many. For instance, in 1953, Dr. Thigpen arranged for Sizemore to sell her lifetime story rights to him and Dr. Cleckley so they could author The Three Faces of Eve. The two doctors paid Sizemore just $3, $1 for each personality. They detailed only 3 of her personalities: Eve White, a demure housewife; Eve Black, a flirtatious and confident party girl; and Jane, a mature and intellectual woman. It was adapted into a 1957 Academy Award-winning film directed by Nunnally Johnson, starring Joanne Woodward, who won Best Actress for her performance portraying the 3 distinct personas. Despite the fame brought by the film and book, Sizemore received only $7,000 for the visual rights to her story, and the film was made without her supervision or authorization, much like the book. Dr. Thigpen arranged for her to have an abortion, which was said to be his child, and during the procedure, she was sterilized without her or her husband at the time's consent. He went on later to attend her husband's funeral uninvited. He was her son's godfather and engaged in sexual misconduct with her. And despite what was said in the book and the movie, her recovery wasn't actually complete until much later in 1975. Christine's identity remained concealed for decades, and she did not publicly reveal her name until the mid-1970s. In her 1977 memoir, I'm Eve, she disclosed her true identity and provided a more comprehensive account of her life, including the existence of over 20 distinct personalities, far exceeding the 3 portrayed in the film and book. She expressed frustration that the original portrayals were a simplified and sanitized version of her complex reality, with the movie depicting only 3 personalities while she had many more. She noted that the film represented the nature of her recovery as the integration of her identities took over 18 years beyond the initial treatment described in the book and was done by completely different therapists. She later wrote A Mind of My Own in 1989, detailing her recovery and the process of integrating her personalities into one unified self. Christine said that while none of the 22 personalities was psychopathic or even violent, with the exception of Eve Black the one time trying to choke Taffy, it was frustrating and somewhat frenetic, encapsulating so many distinctive people at once. Sometimes when she looked into her closet, she would see clothes that she couldn't remember having bought. She would spend an afternoon painting. 7 of her personalities were artists and not even know she had done so the next day. She was aware of something taking place because she felt a presence of the various personalities talking to one another inside her head. But unlike individuals experiencing schizophrenia who hear unknown voices, Christine heard the personalities speaking to her in her own voice. These intellectual personalities sometimes would remind dominant personalities about appointments. One of the personalities thought she was thin when at the time Christine was 5 feet tall and weighed 179 pounds. Another personality would see her body and tell her that she was a big, ugly slob. Despite all the years of therapy, Christine says she didn't feel like she was getting better until the final integration, when all the personalities merged into one, which again was done at the hands of a completely different therapist. Ultimately, Christine became a mental health advocate, using her experience to challenge the stigma around mental illness and to promote awareness and understanding of what we now know as dissociative identity disorder. Shirley Mason, who would later become known as Sybil, was born January 25th, 1923. She grew up in the Midwest in a strict Seventh-day Adventist family. Many who knew Shirley's mother described her as bizarre, and there were some reports that she was diagnosed with schizophrenia. Shirley suffered from blackouts, emotional breakdowns, phobias, and a constellation of physical and sensory symptoms that some believe can be attributed actually to a lifelong and largely untreated case over the entirety of her life of pernicious anemia. However, she entered psychotherapy with Dr. Cornelia Wilbur, a Freudian psychiatrist, in 1954. At the time, both were living in Ohio. Shirley became unusually attached to her psychiatrist, Dr. Wilbur, and she knew that Dr. Wilbur had a special interest in multiple personalities. Sadly, Dr. Wilbur provided treatment to Shirley on credit, loaned Shirley money, found her jobs, and even allowed Shirley to effectively live in her own house. Dr. Wilbur treated Shirley's roommate and persuaded the roommate to take notes on Shirley's behavior. The doctor and patient went on road trips together, and when a dispute arose between Shirley and a niece staying with Dr. Wilbur, it was the niece who got the boot. Dr. Wilbur violated just about every therapeutic boundary with Shirley. Dr. Wilson also began injecting Shirley regularly with sodium pentothal during the course of their intensive therapy, which spanned over a decade from 1954 to 1965. The injections and length of her treatments intensified as Shirley became increasingly emotionally and financially dependent on Dr. Wilbur. She was eager to give her psychiatrist what she wanted. Now, sodium pentothal is often referred to as truth serum, and it was part of the suggestive therapeutic techniques employed to uncover repressed memories and multiple personalities at the time. The drug supposedly helped to display Shirley's parts and allowed for the recalling of traumatic experiences, particularly sadistic abuse by her mother. However, it's known that sodium pentothal produces unreliable confessions and bizarre fantasies, as well as is addictive. So Shirley, who often lay for hours with the needle parked in her arm as Dr. Wilbur asked flagrantly leading questions, became hooked. So Shirley was then also chemically dependent on Dr. Wilbur as well. At one point, Shirley tried to set things straight. She wrote a letter to Dr. Wilbur admitting that she had been lying. Quote, I do not really have any multiple personalities. I do not even have a double. I am all of them. I have been lying in my pretense of them, end quote. Dr. Wilbur dismissed the letter as Shirley's attempt to avoid going deeper in her therapy. Shirley quickly got the message that if she raised questions about the veracity of her multiple personalities, she'd quickly lose everything that she had become dependent on with Dr. Wilbur. And it's important to note at the time, Dr. Wilbur was giving her 14 to 18 hours of therapy each week, coming to her house and eating with her, giving her clothes, and paying her rent. By 1965, Dr. Wilbur diagnosed Shirley as having her personalities integrated, and Dr. Wilbur moved and joined the University of Kentucky College of Medicine in 1967. For several years after her therapy concluded, Shirley lived happily as an art teacher at a community college, even owning her own house. But now I'm going to remind you of that 1957 book and movie, The Three Faces of Eve. So Dr. Wilbur brought in Flora Schreiber to tell Shirley's story for a melodramatic confessional human interest book. Schreiber became uncomfortably aware that a lot of the stories elicited from Shirley by Dr. Schreiber were simply impossible. One of which included a ridiculous tale of a flight to Amsterdam to aid a refugee from the Nazis. Schreiber's own papers point out that it was obvious that the writer knew that Shirley's story was not entirely true. Another example is memories of a traumatic tonsillectomy, for instance, morphed into a lurid story of abuse. Yet in the book, Schneider seemed eager to pump up or even create drama where none existed. Schreiber plowed ahead with the deadline looming, massaging any facts that proved insufficiently sensational to be sensational. After publication of the book Sybil, the true story of a woman possessed by 16 separate personalities, in 1973, it became a hit. Stuart Stern, the screenwriter hired to adapt the Sybil book, was initially skeptical of many of its claims. After only a couple of days in Dr. Wilbur's company, he got on board. Soon he was writing to her, I quote, I found myself wishing more and more that I too could be your patient, end quote. In The Cause of Emotional Truth, he said he insert fiction after fiction to smooth out the parts of Schreiber's book that seemed poorly motivated or downright illogical. Each participant added more fabrications to the story as it passes through his or her hands. Ultimately, the book was made into a highly acclaimed TV movie starring Sally Field and Joanne Woodward in 1976. It was remade in 2007. But the publication of Sybil, the book, destroyed Shirley's life. Schreiber, who had invented so much of what was written in the Sybil book anyway, had so thinly disguised other details about Shirley that many acquaintances instantly recognized her. Too self-conscious to endure this exposure, Shirley fled back to Dr. Wilbur in Kentucky and moved to a home right down the street from her. Shirley lived out the rest of her life as a sort of beloved retainer, cooking her doctor breakfast and dinner every day. In 1991, Dr. Welber developed Parkinson's disease, and Shirley moved into her house to take care of her until her death in 1992. While Shirley's life was destroyed, after publication of the Sybil book, Dr. Wilbur thrived, presiding over the explosion of multiple personality disorder diagnoses as one of the foremost experts on the condition. Within a few years of the book's publication, reported cases of multiple personality disorder leapt from fewer than 100 to thousands. And in 1980, the DSM-3 included the diagnosis of multiple personality disorder itself. Sadly, the multiple personality disorder phenomenon became closely tied to the Satanic Panic, a period of widespread fear about satanic ritual abuse during which therapists used techniques like hypnosis to uncover alleged forgotten memories of abuse, often leading to the discovery of multiple parts. The FBI became involved in some of these cases, particularly when allegations of organized abuse were made. For example, in the case of Patricia Burgess, her therapist arranged for her to meet with an FBI agent to discuss her alleged abuse, and she subsequently accused her parents of sexual abuse, believing that the FBI agent was protecting her from her parents. However, the FBI failed to validate the allegations, which contributed to growing skepticism about the authenticity of many multiple personality disorder diagnoses. The controversy intensified even more when individuals who had been diagnosed with multiple personality disorder began retracting their memories and bringing lawsuits against their therapists because the therapists were creating memories that didn't really exist. And that led to sharp declines in the diagnosis of multiple personality disorder. Additionally, the case of Billy Milligan, who was acquitted by reason of insanity in 1978, due to having 24 personalities, further fueled the debate at this time. While his defense team presented evidence of dissociative symptoms and a history of trauma, including alleged sexual abuse by his stepfather, the case also raised concerns about the influence of media and social environment on the diagnosis. So now we have critics arguing that the diagnosis was being shaped by therapists inadvertently creating symptoms through suggestive techniques like hypnosis, and by cultural factors in media portrayals such as the books of Eve and Sybil. Sadly, Dr. Wilbur played a key role in promoting the belief that conspiracies of fiendish, sadistic adults were secretly perpetrating murder, child rape, and mutilation, human sacrifice, and cannibalism across the country in the 70s and 80s, and that repressed memories of such atrocities lay at the root of most multiple personality disorder diagnoses. Innocent people at the time were convicted of these crimes on the basis of testimony elicited from highly suggestible small children and hypnotized adults. Families were destroyed by therapists who convinced their patients that they'd suffered similar ordeals despite having no conscious memory of it. This opened the door to years of expensive and ineffective therapy. And the outcome of this is that even today, stigma still surrounds those who have experienced childhood trauma, with victims often believing that they deserved, wanted, or imagined their abuse. The dismissal and blatant lack of acknowledgement of traumatic violence remains and may do so as long as it is supported by the theories of Freud, Thigpen, and Wilbur. So we've seen how this has changed and evolved from early recorded cases being supposedly cured through exorcism by moving on to the diagnosis of hysteria, only to then blame anybody who experiences hysteria as having fantasies about something that really didn't happen. And then we move into misrepresentations about multiple personality disorders and how much that winds up influencing how it is that even to this day in 2026, we have so many mental health professionals and medical professionals who do not understand the realities of trauma and how trauma will very often produce dissociation. And if that trauma is caused earlier in life, that it's more likely to lead to dissociation and more severe dissociation symptoms. This has really impacted the entire field and set everything back. But all the problematic elements that are in play, and certainly with those who experience developmental trauma, it also has negatively impacted those who maybe had a relatively average, decent childhood, but then they experience a significant trauma later on. So we'll need to talk about the history of what we now call the PTSD diagnosis. So back in 1914, the term shell shock emerged during World War I to describe a range of physical and psychological symptoms experienced by soldiers, including tremors, headaches, impaired coordination, fatigue, confusion, nightmares, and impaired vision and hearing. Initially believed to result from direct physical trauma caused by artillery shell blasts, the condition soon after was often diagnosed in soldiers who didn't have any head wounds. So as more and more soldiers without proximity to even explosions in the vicinity were exhibiting similar symptoms, the understanding of the condition evolved to being caused by something beyond just purely physical causes. Over time, the term shell shock was shifted to war neuroses or battle fatigue during subsequent conflicts. And despite growing recognition of the psychological toil of combat, early treatments were inconsistent and often stigmatizing, with many viewing the symptoms of shell shock as signs of weakness or malingering rather than a legitimate medical condition. In 1980, the American Psychiatric Association added PTSD to the third edition of the DSM, the third edition of it. Although controversial when first introduced, the PTSD diagnosis stipulated that the agent that caused it was outside the individual. It was a traumatic event rather than an inherent individual weakness, such as a neuroses. In the initial DSM-3 formulation, a traumatic event was conceptualized as a catastrophic stressor that was outside the range of usual human experience. The framers of the original PTSD diagnosis had in mind events such as war, torture, rape, the Nazi Holocaust, the atomic bombings, natural disasters, and human-made disasters. They considered traumatic events to be clearly different from the very painful stressors that constitute normal life, such as divorce, failure, rejection, serious illness, financial reserves, and the like. This dichotomization between traumatic and other stressors was based on the assumption that, although most individuals have the ability to cope with ordinary stress, their adaptive capacities are likely to be overwhelmed when confronted by a traumatic stressor. Today, in the DSM-5 text revision, most developmental trauma survivors do not meet the criteria. You can see here for criterion A, it explicitly states exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. It does say that it includes, but it's not limited to, exposure to war as a combat or civilian, actual or threatened physical assault in which the threat is perceived as imminent and realistic. And they give the examples of physical attack, robbery, mugging, childhood physical abuse, being kidnapped, being taken hostage, terrorist attack, torture, incarceration as a prisoner of war, natural or human-made disasters, and severe motor vehicle accidents. It goes on to say that sexual trauma includes, but is not limited to, actual or threatened sexual violence or coercion. For example, forced sexual penetration, alcohol or drug facilitated non-consensual sexual penetration, other unwanted sexual contact, and other unwanted sexual experiences not involving contact, such as being forced to watch pornography, exposure to the display of genitals by an exhibitionist, or being the victim of unwanted photography or videotaping of a sexual nature, or the unwanted dissemination of those photographs or videos. They say that being bullied may qualify as a criterion A experience when there is a credible threat of serious harm or sexual violence. For children, sexually violent events may include developmentally inappropriate sexual experiences without physical violence or injury. A life-threatening illness or debilitating medical condition is not necessarily considered a traumatic event. So there are a lot of trauma survivors that really have extremely dysregulated nervous systems, but they don't meet the explicitly stated criteria that's currently in the DSM for PTSD, and we are required as diagnosticians to not give a diagnosis unless we explicitly, the client is explicitly meeting these conditions. When the ICD-11 went into effect in 2022, the World Health Organization stepped in and created a category called complex post-traumatic stress disorder, complex PTSD for short, which is not in the DSM-5 text revision, and it is not even included in the DSM-5 text revision section on conditions for further study, which in and of itself is extremely problematic. And this, once again, is part of the legacy of developmental trauma survivors not being taken seriously, even today. Now, the ICD-11 defines complex PTSD as a disorder that may develop following exposure to an event or series of events of an extremely threatening or horrific nature, most commonly prolonged or repetitive events from which escape is difficult or impossible. Now, that works in terms of individuals who have experienced developmental trauma. However, they go on to give the examples of torture, slavery, genocide campaigns, prolonged domestic violence, and repeated childhood sexual or physical abuse. And so those examples are excluding a lot of folks who have suffered from severe amounts of developmental trauma. It also states that all the diagnostic requirements for their version of PTSD must be met. And I'll talk about what those are in just a minute. And again, this, once again, is problematic for individuals who truly have experienced developmental trauma. It goes on in the ICD to state, in addition, complex PTSD is characterized by severe and persistent 1, problems in affect regulation, 2, beliefs about oneself as diminished, defeated, or worthless, accompanied by feelings of shame, guilt, or failure related to the traumatic events, and 3, difficulties in sustaining relationships and in feeling close to others. And that is beautiful. That is exactly what is going to trouble individuals who have experienced complex trauma as that has stemmed from childhood. So now I'll talk about, well, how does the ICD-11 define PTSD? Because you're saying to give somebody this diagnosis of complex PTSD, you've got to meet all the diagnostic requirements for their version of PTSD. So once again, this is literally their words. Post-traumatic stress disorder may develop following exposure to an extremely threatening or horrific event or series of events. It is characterized by all of the following: 1, re-experiencing the traumatic event or events in the present in the form of vivid, intrusive memories. Flashbacks or nightmares. Re-experiencing may occur via one or multiple sensory modalities and is typically accompanied by stronger or overwhelming emotions, particularly fear or horror, and strong physical reactions. 2, avoidance of thoughts and memories of the event or events, or avoidance of activities, situations, or people reminiscent of the events. And 3, persistent perceptions of heightened current threat, for example, as indicated by hypervigilance or an enhanced startle reaction to stimuli such as unexpected noises. And it goes on about how long the symptoms have to persist. They go on to explain that exposure to an event or situation, either short or long lasting, of an extremely threatening or horrific nature, and that such events include, but are not limited to, directly experiencing natural or human man-made disasters, combat, serious accidents, torture, sexual violence, terrorism, assault, or acute life-threatening illness, such as a heart attack, witnessing the threatening or actual injury or death of others in a sudden, unexpected, or violent manner, and learning about the sudden, unexpected, or violent death of a loved one. And that you have to have, following that particular event or situation, then you have to have, for at least several weeks, all of these 3 core elements. You've got to re-experience the traumatic event in the present, in which the event is not just remembered, but is experienced as occurring again in the here and now. And they go on to explain what that looks like. Then deliberate avoidance of reminders likely to produce re-experiencing of the traumatic events. And they explain what that might look like. And then persistent perceptions of heightened current threat, for example, as indicated by hypervigilance or an enhanced startle reaction to stimuli. And part of the problem here, again, for those who've experienced developmental trauma, is that most often when trauma is experienced as a child, whoever's doing that to the child, it's rarely a one-off thing, and the child is very often having to come into contact with this person again and again and again. So the thing is that what has happened will always be locked in the implicit memory that doesn't have words that go along with it. But because it's going to be so distressing, and that person is going to not want to think about that, they're going to live in their left brain, which is all about verbal memory and going on with life. Often they won't be re-experiencing the traumatic event because they're going to be too busy just trying to survive moment by moment. So often you won't have the re-experiencing of the traumatic event. They're going to try to forget about it. It'll be to their detriment, and it's not all, especially the younger this happens, they're not doing this on purpose at all. It's just how they're able to survive. So, saying that somebody has to re-experience a traumatic event and they have to have flashbacks, a lot of individuals who have really early and chronic trauma histories starting in childhood, they're often not going to have flashbacks. That's all going to be extremely locked away. And then it talks about you've got to have deliberate avoidance of reminders likely to reproduce, re-experience the traumatic events. But the problem is that especially the younger someone is, they can't often get away from these people. So you can't meet that criteria either. And while some folks, even after they move into adulthood, some folks may be able to connect with the fact that they have persistent perceptions of heightened current threat, the vast majority won't understand just how strong that is. And some won't even understand that it's going on for them. There's too big of a disconnect. And so if they can't explain it to the treatment provider, then the treatment provider doesn't recognize it. And so once again, we're still stuck, even with the ICD-11, that a lot of folks who experience developmental trauma and should be qualifying for this diagnosis, they're not going to meet it, especially when it says within the complex PTSD diagnosis that all diagnostic requirements for their PTSD have to be met. So it's still, I applaud the World Health Organization for creating this category. There's still a tremendous amount of work that has to be done. So when I'm talking about a lot of work needs to be done, one of the things that neither the DSM nor the ICD-11 are speaking to is the fact that developmental trauma, childhood trauma, is most often the main part of the trauma is about a rupture in human attachment. And that can span the range of physical, sexual, psychological, emotional, religious abuse, as well as all forms of neglect. Neither the DSM or the ICD are speaking to this. To have childhood trauma, it's death by 1,000 cuts. So using really, really strong language like there has to be a threat of death, or somebody has to literally be coming at you in order to attempt to kill you, there are a lot of folks that won't identify with that. And so if they're directly asked about it, or if it happens to be that certain assessments are talking about this, these folks won't connect with it. They won't respond to it. And also, an individual who has experienced repeated childhood traumas, they have a much wider range of symptoms than what either the ICD or the DSM is discussing. I've listed a few of them here. It's not all of them. I mean, everything from chronic migraines or headaches, all kinds of digestive problems, any type of body pain, chronic fatigue, fibromyalgia, panic attacks, feeling really, really lonely, all the mental health diagnoses, environmental sensitivities, dissociation, irritability, anger issues, you name it. I mean, even far beyond what I've listed here. It's all on the table. That's not even a part of either discussion. And so it sets it up to where we still, after all this time, do not have a great diagnostic criteria anywhere for individuals that experience developmental trauma. So in order to figure out how we're going to help individuals who have experienced childhood trauma, we are going to have to get a grasp on dissociation. But dissociation won't just be an important construct for those individuals. Dissociation is going to be a construct for anybody who has ever experienced trauma in their lives. But certainly dissociation, the younger the trauma and the more chronic the trauma occurs for the individual, the more dissociation is going to come into play, and the more that is going to get in the way of the physical and mental health of the individual. So let's be really clear that disassociation is an everyday life process, and it affects everybody. It's part of the continuum of existence, and it's a universal human issue. It's not about pathology. Every human at times is disconnected and disassociated to one degree or another. For example, arriving at a destination without any memory of having driven there is an everyday experience of dissociation. Though not necessarily pathological, this experience helps us see how we can be disassociated and still function in everyday life. So given the long history of human suffering, it is doubtful that our species would have made it this far without the capacity to disassociate. In reaction to trauma, the dissociative process is a life-saving mechanism that helps human beings bear experiences that would otherwise be completely unbearable. If human beings did not have the capacity to disassociate, many individuals would not have survived the hardships of their lives. So compassionate understanding of the pain and fear that drive the dissociative process is critical to healing the earliest and most difficult traumas. Because of early trauma, dissociation is often the only state individuals who have experienced developmental trauma have ever known. In order to dissociate, compartmentalization must occur. A biological basis for understanding compartmentalization in the brain under stress lies in the brain's innate structures, and one of these structures is in the right hemisphere, left hemisphere split. Children are right brain dominant for most of childhood. The slower developing left brain has spurts of growth around the age of language development and then again at adolescence. But the development of left brain dominance is only achieved very gradually over the course of the first 18 years of life. In addition, the corpus callosum, the part of the brain that makes possible right brain, left brain communication, also develops slowly and only becomes fully developed around the age of 12. Thus, in the early years of childhood, right brain experience is relatively independent of left brain experience, lending itself to splitting should the need arise. Studying brain development in children and adolescents, Martin Teicher has observed a correlation between a history of abuse and/or neglect and underdevelopment of the corpus callosum compared to normal controls, which also supports the hypothesis that trauma is associated with independent development of right and left hemispheres, and that deficits in communication between the two sides of the brain may hinder right-left integration, leaving clients who have experienced childhood trauma with two brains instead of one integrated brain. While there is some shared knowledge available to both hemispheres, only the left hemisphere uses language to describe experience and information, while the right hemisphere is more visual, better able to recognize differences and similarities between stimuli, but lacks the words to describe them. The right hemisphere tends to remember episodically and implicitly, whereas the left is specialized for explicit autobiographical memory and acquired knowledge. But the left hemisphere's ability to encode information verbally does not imply that its recollection of events is more accurate. The left hemisphere has a tendency to grasp the gist of a situation, make an immediate inference that fits in well with the general schema of the event, and toss out everything else. This reduces accuracy, but usually makes it easier to process new information. The right hemisphere does not do this. It is totally truthful and does not forget the nonverbal aspects of experience and does not interpret experience. Emotions, researchers have discovered, are experienced in both sides of the brain but can only be verbalized by the left hemisphere. The right hemisphere might act on the emotion but could not describe it in words. And without an exchange of information via the corpus callosum, researchers observed that the left hemisphere might have no memory of the right hemisphere's emotion-driven actions and reactions. So we can see how repeated trauma before age 12 can be housed in the body without verbal descriptions to go along with them. We can also see that while the left brain may make excuses for what is happening in the person's environment, the right brain will not make excuses and will never forget. Attachment research has also contributed to the literature supporting the concept of humans having an innate tendency to compartmentalize under stress. In longitudinal studies of attachment behavior, researchers have demonstrated that children with disorganized attachment status at age 1 were significantly more likely to exhibit dissociative symptoms by age 19 and/or be diagnosed with borderline personality disorder or dissociative identity disorder in adulthood. When attachment figures are abusive, the child's only source for safety and protection becomes simultaneously the source of immediate danger, leaving the child caught between two conflicting sets of instincts. On the one hand, they are driven by the attachment instinct to seek proximity, comfort, and protection from caregivers. On the other hand, they are driven equally by strong animal defense instincts to freeze, flight, flee, submit, or disassociate before they get too close to the frightening caregiver. Dissociative splitting is used to manage this irresolvable struggle between two such strong drives. For children raised in unsafe environments, both types of action systems are necessary in response to changing internal and external demands. For example, going to school requires a part of the personality that can explore, pay attention in class, learn, and socially engage with peers and teachers. At home with caregivers who may be withdrawn or neglectful at some times and violent at others, the ability to rapidly shift from state to state as needed to deal with different threats could be essential. For example, in response to the sound of the abuser's voice or footsteps, panic or fear could alert the individual to danger. Playfulness might lift the caregiver's irritable mood and facilitate a positive connection by making him or her laugh through social engagement. At times, it might be helpful to capitalize on the submission response to become the precociously responsible child who tries to protect younger siblings in the face of violent behavior. But at other times, it could be safer to rely on hypervigilance, staying on guard, carefully observing the caregiver's mood, and reacting in whatever ways best defend against the caregiver's frightening or frightened behavior. These patterns of compartmentalization can be conceptualized as trauma-related procedural learning. It is safer to adapt using a system of selves rather than becoming one fully integrated self, which then increases levels of disassociation. The physical body lives only in the present moment. To manage early trauma, children disconnect from their bodies, emotions, and aggression, foreclosing their vitality and aliveness. The more disconnected we are from our body, the less we are in the present moment. In the mind, we can remember the past or think about the future, but we can be in the present moment only by being fully connected to the body. Early traumatized individuals energetically disconnect from the ground. Disconnection sets up a bad cycle. They also disconnect from other people. This disconnection, though life-saving, produces long-term distress because they feel exiled from themselves and from others. So individuals with histories of developmental trauma tend to be less in their body and therefore less in the present moment. Not living in the present moment, individuals with histories of developmental trauma live life through the filter of past experience, particularly through the filter of unresolved traumas. This leads them seeing other people living in what seems to them like a circle of love, while they themselves live in the distress of feeling on the outside looking in, which heightens feelings of shame and alienation. When adults with early trauma continue to disassociate, this life-saving mechanism comes to function automatically, even though it has outlived its usefulness and is now creating more distress. When individuals with this coping style are asked what they feel, they will tell you what they think. They develop a pattern of living that minimizes relating with other human beings. Friends, career, and relationships are developed to limit connection because too much human contact is overwhelming, and it challenges the disconnected process of disassociation. So we need to look at disassociation on a spectrum. Everybody, if they drive, can experience a trance-like state when they're driving, and they may not remember every single minute while driving from one place to another. Also, everybody daydreams. There's a little bit of disassociation when we're kind of in flow at peak performance because we're really concentrating on one thing and we're leaving other things behind. But individuals with histories of multiple traumas, and especially when those go back to very early childhood, at the lowest level, they'll have dissociative amnesia and fugue. It can move into post-traumatic stress disorder or complex PTSD. It can also move into dissociative disorder not otherwise specified, or dissociative identity disorder itself, and even polyfragmented dissociative identity disorder. So just as a coyote with its leg caught in a trap chews it off in order to escape, in attempting to manage early trauma, the child gives up its unity in order to save itself. Numbing, splitting, and fragmentation create disorganization on all levels of experience. Unmanageable levels of overload overwhelm the child's capacity, and they first manage by numbing. If that doesn't work, then it's by splitting, and then finally by fragmenting. But these life-saving dissociative processes over time exact a terrible cost. So there's two types of numbing experiences: the dimmer state switch and the breaker state switch. The dimmer state switch, many individuals looking back on their experience of dissociation report that they felt as if they had been swaddled with bandages or gauze, and it had the effect of diminishing the intensity of all their experience, particularly their emotions. Some have used the metaphor of coming out of a trance-like state, others as coming off of Novocaine. It's not that they had absolutely no feeling at all, it's just that all feeling had been dulled or muted. The experience of coming out of this dimmer switch state is consistently described as feeling the body more accurately, literally seeing things more clearly, including brighter colors, more visual acuity, and being more present and aware of one's surroundings. Alternatively, the breaker switch state, it's also called shock. It occurs when all emotion and sensation shut off, literally as if a breaker switch had been thrown. This is what is happening if a client says that they feel nothing if you ask them what they feel in their body. Just asking them the question, what do you feel in your body, can be confusing and anxiety producing for them. So we'll move on to splitting. It is natural to react to an inadequately supportive or threatening environment with increasingly aggressive strategies. First there's protest, then anger, and finally, when those are not successful, rage. The problem is that for a vulnerable and dependent infant or child, expressing aggression may create more danger. Disassociation, in addition to numbing the pain created by caregiver failure, also helps children disconnect from their own aggressive reaction to that caregiver's failure. In addition to managing the external threat, infants and children must also manage their own internal aggressive impulses. And they manage this by splitting off, disowning, and projecting aggressive impulses. Split off aggression as the result of early trauma is a psychological and a physiological process. Hate, rage, and the fight response that children feel toward neglectful or abusive caregivers is managed through both psychological splitting and physiological shutdown. From conception, physiological splitting is one of the only and primary protective mechanisms used to manage the overwhelming charge of threats. In later life, this early high sympathetic arousal is experienced consciously or unconsciously as aggression, rage, and hatred. These persistent, destructive, and aggressive feelings are a response to early trauma, particularly the relational traumas of neglect or abuse. Abused and neglected infants and children split off aggressive impulses towards their caregivers in order to maintain their loving feelings for them and to protect the attachment relationship, which is as essential to them as food or air. No matter how neglected or abused children are, they endeavor to protect the love they have for their caregivers by disowning the conscious awareness of their hurt and angry reaction to the hurt that these caregivers are causing them. And we see this because abused children most often defend their caregivers and blame themselves for the abuse they have experienced. A common refrain from abused children is, "My dad really didn't mean it, he was just having a bad day," or "I slipped and got this black eye." Protecting the image of the caregiver can continue into adulthood, saying things like, "My dad wasn't abusive, he took the strap to us a couple times a week, but only when we needed it." So with this aggression, there's two ways it can go. It can be acted in or acting out. When children split off significant aggressive impulses, they see only two possibilities: to identify as good but powerless in acting, or to identify as bad but powerful in acting. So acting in. On one level, abused children see themselves as good but powerless. On another, they experience parental abuse as their own failure, turning their aggressive reactions that are being created by the caregiver against themselves. Children unconsciously think only abusers have anger. I don't want to be like the abuser, so I won't feel any anger. They have anger, but it is split off and it becomes turned inward toward the self. So early traumatized and abused children, without access to their aggression and fight response, feel like outsiders. Their identification with being good but powerless sets them up to be victims. Not able to fight back, these are the children who are picked on by other children who can sense their vulnerability, and it reinforces their experience as victims. As adults with little or no access to their own aggression, they remain identified with a feeling of powerlessness and continue to disown and project their split-off anger and rage. These individuals reenact the role of victim by continuing to act in their aggression against themselves and become psychologically and physiologically symptomatic. Individuals who experience developmental trauma act in their anger in the form of self-hatred. They hate themselves for feeling unloved and unlovable, for never feeling that they fit in. They believe that there is something basically wrong with them, and that the abuse and neglect they experienced is their fault. They hate themselves for their perceived physical flaws and their psychological symptoms. They often feel that their body is their enemy. They hate their body for the fear and distress they experience and may focus their hatred on some real or imagined physical inadequacy. If it weren't for my nose, hips, fat, skin, shortness, tallness, etc., then I would be happy. They have split off significant amounts of aggression. They often present as meek and mild, sometimes very cerebral, and sometimes otherworldly and very religious. They don't know that they are angry except toward themselves, often to the point of self-hatred. Integrating their split-off aggression, learning neither to act it in or act it out, transforms it into healthy aggression is key to reconnecting with the bodily self and to the world, to increase aliveness and to come out of disassociation. The fear that if they allow themselves to feel their anger, they might hurt someone. And so the therapeutic key is to get in touch with and reintegrate the split off aggression slowly, because integrated healthy aggression leads to increased capacity for self-expression, strength, and individualism and individuation. So now we'll look at acting out. Some individuals with early trauma, particularly when they have a history of abuse, begin acting out their aggression as children. Maybe they initially act out against younger children or animals. As adults, power and control become primary themes in their lives. These individuals identify with the bad, powerful aspect of the split, and they act out as abusers and perpetrators. The bad, powerful aspect of the split is expressed as anger against the world. Life is a jungle. It's all about survival of the fittest. I give ulcers, I don't get ulcers. Winning is everything. Some individuals spend most of their lives acting in, living a lifetime of despair and self-hatred, for the most part disconnected from their anger. But for some, the aggression that has been turned against the self erupts and is acted out against the environment, sometimes in a violent way. So at the most extreme end of the disassociation spectrum is fragmentation. When trauma is particularly severe and/or ongoing, many individuals use fragmentation as a coping mechanism to manage overwhelmingly high levels of arousal and painful emotions. When fragmentation occurs, there will be an aspect of self driven by daily priorities as the going on with life part of the self, and other traumatized parts driven by the survival defense responses of fight, flight, freeze, submit, or attach. Each part represents a way of surviving dangerous conditions and a different approach to self-protection. The parts are not simply repositories of memory. They are the means of surviving the worst of the worst, not a means of remembering it. However, as the carriers of instinctive survival responses, the parts remain poised for the next threat or the next trauma-related trigger decades after the initial trauma was over. Fragmentation can be more subtle and permeable, or more dramatic and rigid. Some clients might shift between clear-cut states, sometimes irritable, sometimes depressed, at other times anxious. Other clients might present at times as regressed and clinging, at other times cold and angry, at other times hopeless and passively suicidal, and all of this while functioning fairly well at work. Other clients might have clearly observable compartmentalization and some difficulty with memory. Other clients might exhibit switching and time loss as they are hijacked by parts who, when triggered, act outside the conscious awareness of the going on with normal life part of the self. So it becomes really important that we can recognize the symptoms of structural dissociation when it is happening in front of us in a counseling session. So how can we know if that is happening? Well, certain symptoms can alert us to the presence of underlying structural dissociation. One of that is signs of internal splitting. Some examples can include The client functions highly at work when stimulated by work assignments, collaboration with peers, and responsibilities, while regressing at home or in personal relationships because of the trauma triggers associated with those environments. Or the client might report alternating fears of abandonment, followed by pushing away those who try to get close, or a tendency to initially idealize others, followed by disillusionment and anger when they fail the client in some way. The fears of abandonment represent communications of the attach or cry for help part, as closeness to others exacerbates that part's separation anxiety. But the pushing away is the response of a fight part activated by the risk of vulnerability or hurt. So splitting often manifests in paradoxical behavior. Fears of triggers might be intense, while the client lacks appropriate fears for real threats. For example, the client may plan a family vacation for the following summer while simultaneously ruminating about completing suicide. Or a client might describe himself as enlightened, kind, and reasonable, while family and friends portray him as typically angry, arrogant, and demanding. This can also show up in somatic symptoms, which are just body, any kind of body symptoms. You stub your toe, it's a somatic symptom. But unusual pain sensitivity or uncharacteristically high pain tolerance can be indicators. Stress-related headaches, sleep issues, and physical symptoms with no diagnosable medical cause can be trauma-related or a symptom of dissociative activity. For example, a collapsed left shoulder and a tense raised right shoulder might be evidence of a submissive part on the non-dominant side of the body and a part ready to fight connected to the physically stronger dominant side of the body. Sadly, one of the most common indicators of structural dissociation is atypical or non-responsiveness to psychopharmacological medications. So a lot of the medications that we're using to treat mental health disorders like anxiety, depression, schizophrenia, those kinds of things, it can sadly be, if somebody is dissociating, often those medications don't really work. We also need to look out for regressive behavior or thinking. So sometimes the client's body language seems more typical of a young child than an adult of his or her chronological age. They might appear shy, collapsed, fearful, unable to tolerate being seen, or unable to make eye contact. The message might be, "I'm scared, don't hurt me," or "Please notice me, please like me," or "Please don't leave me." Verbal and cognitive style can also reveal the presence of younger parts of the self. Maybe there's concrete or black and white thinking. Maybe they use words or style of expression that's more typical of a child than an adult. Children use shorter sentences, express themes related to separation, caring, and fairness, and are more likely to feel empathically failed when they are not well understood. Another thing to look out for is patterns of indecision or self-sabotage. Often misrepresented as ambivalence, a client's inability to make small everyday decisions or problems with carrying out his or her expressed intentions can reflect conflicts between parts with opposite aims. Often this phenomenon manifests in frequent changes of job, career, or relationship, or a history of success in life, alternating with self-sabotage or inexplicable failure. High functioning alternating with decompensation. Hard work being suddenly undone by self-destructive actions. Very crucial life decisions can be involved, but often this pattern appears in difficulties in daily living, such as an inability to choose what to wear in the morning, what to eat for breakfast, or even whether to keep a date with a friend for lunch. Memory symptoms are something else we should look out for. While memory gaps and time loss are cardinal symptoms of dissociative disorders, more subtle memory problems can be indicative of structural dissociation. For example, all of the following memory issues are common manifestations of parts activity: difficulty remembering how time was spent in a day, difficulty remembering conversations or the focus of past therapy sessions, blackouts, getting lost while driving somewhere familiar, forgetting well-learned skills, or engaging in behavior that one does not recall. And lastly, we want to look for patterns of self-destructive and addictive behavior. Many studies have demonstrated correlations between suicidality and self-harm and addictive behavior with a history of trauma. So it should not be surprising that traumatized clients can struggle against their own self-destructive behavior. While the going on with normal part of life of the client seeks therapy because he or she is committed to life, to wanting all the things everyone wants, fight parts can engage in high-risk behavior or attempt to harm the body or end life in an effort to get relief from the implicit memories that the body is still holding at any cost. Parts that are driven by flight responses tend to engage in eating disorders, numbing, or addictive behavior that alters consciousness, allowing distance from unbearable feelings and flashbacks. Fight-related parts are prone to more violent actions, whether aggression towards others or self-harm and suicidal behavior. In a pilot study using the structural dissociation model with a group of severely symptomatic inpatients hospitalized for 2 to 10 years to prevent intentional and unintentional suicide, 6 of the 8 subjects demonstrated marked improvement after a year of psychoeducationally based treatment focused on strengthening the ability of the going on with normal life part of self to identify and separate from the impulses of the self-destructive parts. All right, so we've been talking about parts. This graphic was created by the National Institute for the Clinical Application of Behavioral Medicine, and it talks about the structural dissociation model, and you can see that the left brain is the going on with normal life part of the self, while the right brain houses the implicit memories of the trauma. The neurobiological and psychological effects of a dysregulated autonomic nervous system create disorganized attachment patterns and structurally dissociated parts that become a set of well-entrenched, familiar, habitual responses. The person will be unconsciously driven by a post-traumatic implicit procedural learning activated by trauma-related triggers in the present moment that have just become a part of who they are. Although apparently unrelated to the past, these just who I am responses are the conveyors of an implicit narrative that cannot fully be remembered or put into words. A history held by different parts with different perspectives, triggers, and survival responses. Trauma survivors all too often develop other symptoms that represent attempts to cope with the trauma: self-injury and suicidality, risk-taking, reenactment behavior, caretaking and self-sacrifice, re-victimization, and addictive behavior. All of these behaviors represent different ways of modulating a dysregulated nervous system and preparing for the next threat. Self-injury and planning suicide induce adrenaline-related responses of power, icy calm, control, and physical strength, but also a relaxation effect from the increased production of endorphins. Restricting, binging, and purging and overeating all induce emotional and bodily numbing. And addictive behaviors can be tailored to evoke either numbing or increase arousal or do both. Historically, in the mental health field, we've addressed these issues by first stabilizing unsafe behavior and then treating the traumatic events. But narrative memories are connected to intense states of autonomic arousal. Because the activation readies us for danger, remembering is likely to reactivate self-destructive impulses. Even thinking about the traumatic memories is often enough to cause a reactivation of the nervous system as if the events were recurring in the here and now. This is why EMDR and other talk therapies often do not completely work or even make the client worse. When the client's symptoms represent implicit memories held by trauma-related parts, expressing emergency and survival responses, individuals continue to feel unsafe and their parts continue to defend as if they're being threatened right now. When trauma responses are misinterpreted in these ways, it threatens the parts. It feels like proof that they are endangered, defective, or trapped in a hopeless situation. So once again, the felt sense is that they're in danger without protection and all alone. Without an understanding of post-traumatic implicit memory or structural dissociation, not knowing that they have been triggered by some cue reminiscent of the past, they interpret fear, shame, and anger as signs of imminent danger or deep-seated inadequacy. It can be a relief for them to discover that their stuckness, resistance, chronic depression, fear of change, entrenched fear and self-hatred, crisis and conflict, even suicidality, all can be communications from parts who fear for their lives, unaware that the dangers they are bracing against are now in the past. Disappointment, criticism, closeness, or distance, even authority figures, may no longer be life-threatening, but each nonetheless evokes trauma-related implicit memories and the parts that hold them. Helping clients learn to become curious and interested in their symptoms and able to identify the voices that speak through their reactions from the parts can change their relationship to themselves and the past from one of shame and dread to one of compassion. Knowing that each part is charged with the mission to survive, each in its own way helps clients to see how they survived and was more crucial than how they were victimized. Understanding how each part participated in survival increases the sense of we together and challenges the sense of being abandoned and alone. Feeling warmth and empathy for young wounded cells feels healing and comforting. So I've been speaking about the structural dissociation model. That was created by Steele, Vanderhart, and Nijhuis. And this graphic was created by didresearch.org. It kind of helps to explain what they're thinking about here with the structural dissociation model. I do want to explain what these terms mean, and I won't be using those terms. In the model, you can see on one side we have something that's labeled A and P. The individuals who created this model considered the A and P to be the apparently normal part of the self. And honestly, that's for anybody who's experienced a trauma to label a primary identity as an apparently normal part of the self is just very wounding. So I never talk about it in those terms. And the only way I would do that is if we go around and we claim that every human being only has an apparently normal part of themselves. And it also suggests that people can never overcome this. Like if you've had trauma and you've experienced either simple dissociation or a single incident post-traumatic stress trauma, it's just not great. So instead of calling it AMP, I talk about it in terms of the going on with the normal life part of self. And also in the original model, the EP side here stood for emotional part, which again suggests that emotions are bad and they're weak and extremely problematic. So we most folks don't use these terms. So there's in this model of primary structural dissociation, where you have somebody who maybe has experienced one major trauma in their life, then you've got this going on with the normal aspect of the self that's responsible for everything that the individual is doing. And then because of the trauma, because of implicit memory that's going to be held in the body because of the trauma, that then you can have a traumatized part. And it could look like any number of these things. It could be a few of these things. It could be a lot of these things, but they can do anything from be hypervigilant to do a lot of fight, flight, freeze, submit, or just disconnect from their body completely. But we can see here how when somebody maybe has only had one big trauma and it's caused a typical PTSD reaction, what that might look like. Now we move up a level in the structural dissociation model, where there's a category called secondary structural dissociation. Now, here we have one going on with the normal part of life self that's really responsible for getting everything done. But here the trauma is more complex, and we have different parts that that exist within the individual, because at different times there were different strategies that needed to be used to survive those different experiences, traumatic experiences that they had. So the one thing with secondary structural dissociation, you'll always have one main going on with life part of self, but they're showing three traumatized parts. It could be two traumatized parts, or it could be 50 traumatized parts. So the main thing here, in primary, you've got one going on with life part of self, and you really have one traumatized part that really has one way of dealing with trauma. With secondary, you've got one going on with life part of self, but you have at least two or more traumatized parts that had to use different techniques to survive. And here's where most folks who are getting diagnoses of complex PTSD, the other specified dissociative disorder diagnosis from the DSM, potentially things like a personality disorder if that manifested, although not everyone who had developmental trauma deserves to receive or should receive any type of personality disorder diagnosis, because that is not appropriate. That doesn't mean that just because somebody has experienced childhood trauma that they will meet that definition. So it's not a given. It's just, you can see that now we're moving up a line, we're moving into deeper levels of diagnoses with secondary structural dissociation. Then at the highest level, there's tertiary structural dissociation. What you have here is at least two or more going on with life parts to the self. There could be two, there could be 50. And then also you've got at least two or more traumatized parts, but often if there really is a split in how the division of activities are being played out in an individual's life with more than one going on with life part of self, often you're going to have more than just two traumatized parts. Here they happen to show two going on with normal life parts of self and three traumatized parts. But again, to get to tertiary structural dissociation, we have at least two or more going on with normal life part of the self. So you can see in this example, one going on with life part of the self is focused on daily life, social engagement, exploration, and play, while the other one is focused on rest, eating, and sexuality. Often individuals who are at this level are getting diagnosed with things like dissociative identity disorder. It can help you to see these graphic representations to kind of help you understand what it is that we're talking about when we're talking about structural dissociation, and that there's primary, secondary, and tertiary levels. When someone suffers from dissociation, it's usually not their presenting complaint. Extensive research indicates that people suffering from dissociation seek treatment for depression, anxiety, mood swings, hearing voices, attention problems, obsessive compulsive symptoms, addictions, self-destructive behavior, and body pain, basically everything but dissociation. But optimal care depends on an accurate diagnosis. And as you heard from the history, a lack of reliable methodology for diagnosing disassociation leads to misdiagnosis, ineffective treatment, and unnecessary suffering, sometimes lasting as many as 50 years. So before we could figure out diagnostic methodologies, the underlying dissociative condition had to be understood. And it's only been over the last 35 years that the basic components of disassociation have been examined systematically and clarified on the basis of large-scale, replicable investigations. Until then, lack of empirical research led some mental health treatment providers to wonder whether dissociative identity disorder, the most complex of those disorders, was a genuine condition. And when they did accept the disorder's reality, diagnostic methods varied in sensitivity, with missed cases of disassociation risking decompensation due to the lack of trauma-informed treatment. Sadly, the most well-known assessment tool, the Dissociative Experiences Scale, which is a self-report instrument, is the easiest to administer, but unfortunately is the least reliable tool. Clinicians using it report high rates of false negatives, and that's very low scores in clients who literally demonstrate very obvious DID symptoms later on. For example, switching parts during a therapy session. And these false negatives can be dangerous if they give the therapist a green light to go ahead with therapeutic work like EMDR that exceeds the client's window of tolerance and activates the parts to act out self-destructively. So remember that in 1957, the book and movie The Three Faces of Eve was a huge hit. Also remember that the book Sybil, the true story of a woman possessed by 16 separate personalities, was a huge hit in 73, followed by the movie in 76. And remember that multiple personality disorder was placed into the DSM-3 for the first time in 1980. However, back then, there was no coherent theoretical framework for understanding dissociation. So those high-profile cases like Eve and Sybil captured both professional and public imagination, and clinicians needed an accessible way to identify dissociative symptoms in both research and therapeutic settings. So the DES was developed in 1986, and by the early 1990s, the DES had been adopted in a wide range of studies and was frequently used to assess dissociation in both clinical and non-clinical populations. Because of its ease of use and strong statistical properties, it quickly became the go-to screening tool for dissociative tendencies. And as a result, the DES appears in hundreds of studies and has profoundly shaped how dissociation is defined, measured, and interpreted in both clinical and empirical contexts. In the decades since 1980, the theoretical landscape has evolved significantly. A major limitation of the DES is its emphasis in overt, visually striking forms of dissociation, such as depersonalization, derealization, and the feeling as if one is observing oneself from outside the body. As a result, the DES privileges what might be called cinematic dissociation, detachment symptoms that are both culturally recognizable and consciously accessible. This creates a sampling and measurement bias. Individuals who experience these dramatic, often disorienting states may score highly, even if their symptoms are transient or not functionally impairing. Meanwhile, those whose dissociative processes are subtle, developmentally ingrained, or normalized may not endorse these items at all. And it's not because they lack dissociation, but because their internal experiences don't conform to the scale's language or assumptions. The DES is thus skewed towards the kind of dissociation that other people can notice and against the kind that is hidden even from those who live with it. And I can tell you from personal experience and the experiences of many others that they are completely unaware, because especially when there's been a lot of trauma, and especially when there's been a tremendous amount of trauma before age 12, they have no idea they're dissociating because it's just the way things have always been. Another new major development is the distinction between detachment and compartmentalization dissociation. Detachment refers to a subjective sense of disconnection from the self or environment, such as feeling unreal or watching oneself from the outside, and is commonly associated with both depersonalization and derealization. Compartmentalization, by contrast, involves a disruption in the normal integration of memory, identity, emotion, or perception, leading to phenomenon like dissociative amnesia, identity discontinuity, or functional neurological symptoms. The theory of structural dissociation builds on the notion of compartmentalization by proposing that trauma can cause enduring divisions between distinct subsystems of personality. Structural dissociation represents a subtype of compartmentalization in which dissociative barriers form between these systems, impeding full access to memories, emotions, and actions. While detachment symptoms are more common in the general population and often associated with transient stress responses, compartmentalization, especially in its structural form, is central to complex dissociative disorders like DID. A related but distinct issue lies in the inclusion of absorption. Absorption is a trait-like capacity for deep immersion in inner experience, which is a core dimension of DES scoring. Roughly a third of the DES's 28 items load on the absorption factor, which describes completely non-pathological normal states like daydreaming, becoming engrossed in a novel, or imaginally entering an internal fantasy world. Example items on the DES ask whether one becomes so involved in a fantasy or daydream that it feels as though it were really happening, or gets lost in a movie and loses awareness of surroundings. While these experiences are dissociative in a loose phenomenological sense, they are common in the general population and not inherently pathological. Studies have shown that elevated DES scores often reflect high rates of absorption rather than trauma-related compartmentalization. The result is a high false positive rate. Individuals who are imaginative, sensitive, or introspectively attuned may receive scores suggestive of dissociation without having any form of a dissociative disorder. Because the DES does not distinguish between absorption and structural dissociation in its scoring system, It risks pathologizing normal cognitive styles and inflating prevalence estimates of dissociation in both research and clinical contexts. An additional concern is the DES's vulnerability to confound dissociation with fantasy proneness. Several studies have shown that high DES scores in non-clinical and psychiatric populations often correlate strongly with measures of fantasy proneness. This means that individuals who score highly on the DES may not be dissociative in a clinical sense, but instead exhibit a vivid imaginative life, high suggestibility, or a proclivity for absorption and fantasy. Importantly, research has shown that individuals with clinically diagnosed DID are not more fantasy prone than controls. Studies that report correlations between fantasy proneness and dissociation typically rely on the DES scores as the measure, meaning that they are measuring what the test measures, not the underlying construct of dissociation. So because the DES is widely treated as a proxy for trauma-related dissociation, its correlation with fantasy proneness has led to a broader conceptual conflation in the literature. Some researchers have interpreted elevated DES scores as evidence that dissociation itself is merely a cognitive style that reflects the person being suggestible, being able to absorb, or imaginative involvement, rather than a marker of trauma-related psychopathology. Others have used this correlation to argue that dissociation is inherently unreliable or prone to response bias. And while fantasy proneness may indeed mimic some dissociative symptoms, and for some people it could co-occur, and people could have both, it is not synonymous with structural disruptions seen in clinical dissociative disorders. However, due to the DES's widespread use and the ongoing lack of conceptual clarity around trauma-related dissociation, fantasy proneness and dissociation have become routinely and indiscriminately correlated in the academic literature. This ambiguity in what the DES actually measures muddies the water in both clinical assessment and research. It encourages circular reasoning. Studies define dissociation via DES scores, then identify traits like fantasy proneness as characteristics of dissociative individuals, when in fact those traits may be driving the score itself. Without tools that can differentiate between fantasy-based immersion from trauma-induced compartmentalization, the field risks making a false equivalence between imaginative capacity and pathological dissociation. However, the most fundamental limitation of the DES is that it fails to measure the core mechanism that defines pathological dissociation in contemporary theory, which is compartmentalization. Compartmentalization is the rigid internal segregation of knowledge, emotions, and experience, often resulting in discontinuities that the individual is completely unaware of. These manifestations include memory fragmentation, state-dependent access to information or emotions, contradictory self-perceptions that are not recognized as inconsistent, and sudden involuntary shifts in mood, behavior, or perspective in response to cues. The DES can't detect these symptoms. It contains only a handful of items related to amnesia, and all of those rely on overt behavioral indicators and draw from those books and their scripts that came out in the 50s and the 70s. And there's no questions that assess internal shifts, intrusions, or conflicts between disintegrated aspects of experience. Because this instrument relies entirely on self-report, it cannot detect the very phenomenon that are inaccessible to conscious awareness, and that's precisely the hallmark of structural dissociation. As a result, the DES is effectively blind to the most defining and most impairing features of complex dissociative disorders. Additionally problematic, the DES uses a 0 to 100% percentage of time scale for each item, but this format is unusual and poorly specified. Respondents are asked to estimate how often they experience certain dissociative phenomenon without any clear time frame, like in the last week, in the last 2 weeks, in the last 6 months or year. This omission leads to high variability in interpretation. Some individuals may answer based on recent memories, while others will draw on their total life, making comparisons across participants statistically unreliable. The reference context of each question is also ambiguous. For example, the first question is, some people have the experience of driving or riding in a car or bus or subway and suddenly realizing that they don't remember what happened during all or part of the trip. Select the number to show what percentage of the time this happens to you, 0% never to 100% always. It's unclear whether this question asks how often such experiences occur during transportation specifically, or how often they occur in general. Further ambiguity arises. Does the percentage refer to how often one realizes the memory lapse or to how often one experiences memory loss, something that by definition one may not be aware of? Without consistent instructions, respondents are left to guess what exactly they're being asked to quantify. No other widely used psychological instrument uses a 0 to 100% format. Standardized tools typically use the categorical frequency options from never, sometimes, often, and define a fixed time window. These conventions support greater consistency and allow for meaningful clinical thresholds, features that the DES lacks. Furthermore, the requirement to quantify dissociative phenomenon as a percentage of time is especially ill-suited to dissociative populations. Individuals with memory loss or compromised self-awareness are being asked to assign precise numerical values to experiences they may not fully remember or recognize. This creates a paradox. The more severe the dissociation, the less likely the individual is to accurately report on it, yet the test depends entirely on self-report. So the DES's percentage-based format undermines the validity of its scoring. It gives the illusion of objectivity while producing internally inconsistent and externally incompatible results. While a single respondent may show score stability over time, inter-individual comparisons are unreliable, limiting the tool's utility in both research and diagnostic contexts. Low scores on the DES are often attributable to 3 factors. 1, symptom presentations that diverge from the culturally dominant DID stereotype that began, well, really it began from the time of recorded history, but certainly the release of the 3 Faces of Eve and the Sybil book contributed widely to what's out there. 2, unfamiliarity with dissociative terminology. And 3, a mismatch between lived experience and the DES's phrasing. Many of these individuals also describe a substantial increase in their DES scores after receiving a diagnosis as they become more aware of previously unrecognized dissociative symptoms. This trend reinforces the concern that lack of awareness, both conceptual and experiential, can significantly depress initial DES scores. And I can say from personal experience, that's exactly what happened to me. But this has significant implications. Low DES scores lead counselors and researchers to falsely conclude that dissociation is absent, overlooking individuals with fragmented internal structures who are unaware of their own discontinuities. So this delays accurate diagnosis and leads to misattribution, such as labeling the symptoms as mood or personality disorders. Now we can have also high scores in people who don't dissociate. So it's been repeatedly reported in the academic literature that the DES often produces high scores in individuals without a dissociative disorder. One study reported that only 17% of individuals scoring above 30 on the DES actually met the criteria for DID. But remember that elevated DES scores can also result from non-dissociative traits such as absorption, fantasy proneness, psychological distress, or even suggestibility. This is particularly relevant in online spaces where high DES scores are frequently used as the basis for self-diagnosing dissociative disorders. Social media and community forums often encourage individuals to take the DES and interpret the result as an indicator of dissociation. But the tool's broad inclusivity means that many high scorers are better understood as people who are introspective, imaginative, or highly influenced by cultural scripts, not dissociative in a diagnosable sense. This leads to overdiagnosis and reinforces the conflation between imaginative cognitive styles and actual pathological dissociation. Although some recent studies have attempted to map DES items to newer models, these efforts remain limited by the instrument's foundational assumptions. It still completely excludes many dissociative phenomenon, particularly subtle or internal ones that fall outside the purview of the initial 1980s framework for what dissociation was supposed to be. And so this risks circular reasoning. Using the DES to define dissociation reinforces the very assumptions embedded in its construction, while overlooking what we now know to be the full range of the concept of clinical dissociation. There's a litany of short screening tools, like some of them just focus on depersonalization and other things. All of them are exceptionally problematic. I even hesitate to bring up the multi-scale disassociation inventory. It's a questionnaire. It has 30 items, and people look at those and range them from 1 to never to 5 very often of different dissociative experiences that have occurred over the past month. Again, just like the DES, it's a screening tool. You can't diagnose off of this. It has been normed and standardized. But it still is really, really lacking on a lot, just so much of what we know to be a part of dissociation. And there's so many people that if the MDI is used, that it wouldn't catch them, that I don't think this is worth using honestly at all. But if we're talking about these types of scales, it's probably the best thing out there. So when it comes to screening, what might be something to use? And that, at least at this point in time, probably the trauma symptom inventory 2 could be used. This is also a self-report instrument. Again, this is not to diagnose. You cannot use this to diagnose anybody with anything, but it's a screening tool. It elicits information about a range of symptoms from dissociation to intrusive images, sensations, anxiety, and depression, and behaviors like self-harm, impulsive behaviors, and addictions. So it doesn't explicitly diagnose DID. It also, you can't diagnose PTSD with it, but it does have a scale, and so you can get a feel for severity of a dissociation score. And when clients score high on that symptom cluster, you can use that as an objective statistic, usually along with other related scores on this, that provides a very natural entry point for a discussion of dissociation and dissociative disorders, as well as potentially a trauma diagnosis. So the TSI-2 is a 136 item self-report measure of post-traumatic stress and other psychological issues that go along with traumatic and stressful events. It was updated in 2011, and so it also can look at things like emotional neglect and experience of loss, which is super, super handy. Symptom responses are not tied to a particular event or time span, and they're asked to rate how often each symptom has happened to them in the last 6 months. They're rated on a 4-point frequency scale from 0, never, to 3, often. And you can see it's got 12 clinical scales. Some of these scales actually have subscales. And the nice thing about giving this to everyone is that it's a good way to screen for a host of issues with an individual, and can be really, really helpful as you're beginning counseling practice with them. So if you were going to use a screening instrument, this is probably the better way to go, and then move forward from there. All right, so now let's move on. How are you going to diagnose the dissociation that can come as a part of experiencing trauma? So Steinberg describes 5 symptom clusters that are characteristically found in dissociative disorders that facilitate making the diagnosis. One of them is dissociative amnesia, or missing time. So if somebody is missing periods of time after the age of 9, or gaps in daily memory that aren't explained by normal forgetfulness. A subset of this is dissociative fugue, and that's where people can find themselves in an unfamiliar location with no memory of having planned to go there and no recognition of the other people around them. Sometimes fugue episodes are accompanied by dissociative amnesia, the loss of memory for personal information such as one's name, address, age, and job, or significant others. Another common categorization is depersonalization. That could be feeling disconnected from oneself or one's experience. There can be depersonalization, experiencing other people or familiar surroundings as unreal. There's identity confusion, which is the basic question is, who am I? Am I the person who functions? Is that a false self? Am I needy and clingy? Or am I extremely independent? Do I want to live? Do I want to die? And then identity alteration, regression experiences, feelings or behavior that don't feel like mine, being known by different names, evidence of child parts, like the person having stuffed animals, sucking their thumb, being extremely afraid to be alone, or evidence of activities for which one has no memory. It can also include psychotic-like symptoms such as hearing voices, internal dialogues, intrusive voices, thoughts, images, visual hallucinations of the trauma. Those can all be signs of a dissociative disorder. All of those symptoms will represent implicit memory and or manifestations of traumatized parts of the self, but unfortunately tend to be diagnosed as symptoms of schizophrenia. And remember, I talked about this earlier, and that's why I brought it up in the history section about how it's really critically important that we know how to distinguish between voices as an outcry of schizophrenia versus voices that are an outcry of dissociation. So researchers compared the voices described by individuals experiencing schizophrenia with the voices recorded or reported by a group of patients who were diagnosed with dissociative identity disorder. And the researchers found that the DID subjects reported hearing voices at a more frequent rate than those who experienced schizophrenia. The DID individuals described the voices as having different genders and ages, and they summarize the content of the voices' communications as generally negative and personally directed towards them, focused on pointing out the individual's inadequacies, lack of worth, and using these accusations to justify why the person deserves to die. Alternatively, the voices reported by individuals experiencing schizophrenia were fewer in number, did not have different ages or genders, and spoke from a more abstract spiritual or paranoid perspective, but not a personal one. Even if the voices were telling them to hurt themselves in some way, it wasn't, the voices weren't constantly telling the person sort of what a failure that they were. Now, I talked earlier about screening assessments, and we really only have one good, true diagnosis level assessment for disassociation. And that is the multidimensional inventory of dissociation, the MID-6. The MID-6 was explicitly developed to address the limitations of the DES, particularly in its inability to distinguish between pathological dissociation and just normative absorption and fantasy. It measures a broader and more granular set of dissociative symptoms, including amnesia, identity confusion, and internal voices. It's a self-report questionnaire, but requires clinician interpretation and training, using a detailed scoring manual and algorithm, making it more time-intensive than the DES, but substantially more accurate. It assesses dissociative experiences very broadly and deeply. Of the 218 items, 168 tap dissociative experiences. The remaining 50 are validity items, which are very, very important if we're going to use any kind of assessment to make a diagnosis. The MID-6 measures 23 dissociative symptoms and has 74 different scales, which is awesome. The MID analysis differentiates and offers a diagnostic impression regarding the following clinical presentations. So it can help the counselor differentiate between dissociative identity disorder, other specified dissociative disorder type 1A, which is in the ICD, from other dissociative disorder type 1B, which is what's listed in the DSM, versus unspecified dissociative disorder, versus post-traumatic stress disorder, versus post-traumatic stress disorder with the dissociative subtype, versus functional dissociative neurological symptom disorder, as well as a measure for problematic and severe traits indicating borderline personality disorder. So this can really help tremendously in sorting out what's going on. Once an individual is independently licensed, they can contact the publisher and they can gain access to the assessment and the manual, as well as then needing to go through training on how to use that. I had talked about that this the MID has 74 clinical scales. The broad categories of the clinical scales include validity and characterological scales, functionality and impairment scales, general post-traumatic dissociative symptoms, partially dissociated intrusions of another self state, fully dissociated actions of self states, which is also known as amnesia, self-alteration, self states and alters, first-rank symptoms, and additional scales. Using it can really, really, really help you understand what is going on with the individual who is sitting in front of you, which can be extremely helpful. So this is something to keep in mind. No matter what, you definitely need to know about, in terms of diagnosis, there is the gold standard for making a diagnosis, which is actually a diagnostic interview. It's the structural clinical interview for DSM, dissociative disorders, affectionately known as the SCID-D. So the SCID-D is a semi-structured clinical interview assessing dissociation in adults and adolescents that is administered by licensed professionals. It assesses dissociative amnesia, depersonalization, derealization, identity confusion, and identity alteration as an adaptive survival mechanism employed in the face of adverse life experiences. Unlike the DES, it enables clinicians to detect symptoms in the patient that they may not report on their own. It is considered one of the most reliable tools for diagnosing dissociative disorders in clinical settings and is often used in research. It's based on Dr. Steinberg's 5-component model of dissociation assessment. So 1, amnesia refers to a subjective sense of gaps in one's memory for autobiographical information or experiences, or for blocks of time that have passed, where such lapses cannot be attributed to ordinary forgetfulness. 2, depersonalization refers to a feeling of disconnection from oneself, and that could be from one's feelings, thoughts, behavior, or body, or a sense of being an outside observer of oneself. 3, derealization refers to a feeling of disconnection from one's surroundings. That could be people or surroundings feel as if they're unfamiliar, unreal, or distorted. 4, identity confusion refers to subjective feelings of uncertainty, puzzlement, conflict, or struggle regarding one's own identity or sense of self. Identity alteration refers to observable behavior associated with alterations or shifts in one's identity or personality states. So just as all colors can be obtained by mixing the primary colors, red, yellow, and blue, so all post-traumatic dissociative experiences can be understood as consisting as a mixture of these 5 components. As with the primary color, the intensity of each component varies along a spectrum. On one end, each can be a normative, transient coping mechanism that does not cause dysfunction or distress. On the other end, each can be recurring or ongoing, interfering with relationships, causing internal suffering, or otherwise impairing functioning. So consider flashbacks, which is a common dissociative experience. What mixture of these components constitutes a flashback? People who experience traumatic flashbacks feel disconnected from their current surroundings, which is derealization, behave as they would have at the time of the trauma, which is identity alteration, and have memory lapses for events happening around them in the present, which is amnesia. Another common dissociative behavior is sleepwalking. An individual who sleepwalks has no recollection of their sleepwalking activities, amnesia, and may behave very differently from how they usually would, which is an identity alteration. All other dissociative experiences may be composed in this way using the 5 primary components as building blocks. Similarly, specific dissociative disorders can also be characterized by their various combinations of the 5 components. For instance, a moderate to severe level of amnesia with none to mild levels of the other 4 symptoms characterizes a diagnosis of dissociative amnesia, whereas moderate to severe levels of all 4 or 5 components characterize dissociative identity disorder. Particular dissociative disorders correspond to distinct mixtures of severity levels for each of the 5 components, ranging from normative to problematic, as specified by applying the SCID-D severity rating definitions. Dissociative symptoms and disorders are commonly underdiagnosed in part because they often occur outside of an individual's conscious awareness. When dissociative symptoms are misattributed as due solely to depression, anxiety, psychosis, addictions, attention problems, or post-traumatic stress disorder, failure to diagnose the underlying dissociative disorder can lead to higher rates of hospitalization and suicide attempts and prolonged suffering. Early and accurate detection of dissociation using the SCID-D reduces these risks. Too frequently, systematic assessment for dissociative disorders is overlooked, and the external signs of dissociation, for example, intrusive thoughts, mood swings, and body pain, are not linked to underlying dissociative conditions. And the failure to detect dissociation can lead to ineffective treatment, higher rates of hospitalization and suicide attempts, and generally prolonged suffering. The SCID-D allows clinicians to uncover this connection. By inquiring about the core components of dissociation, the interview gathers the information necessary to look beyond the outermost signs, like depression, anxiety, mood swings, and flashbacks, to establish whether the underlying ailment is actually dissociative. Like the radiologist's x-rays, the SCID-D reveals the internal structure of dissociation, thereby suggesting a roadmap for effective dissociation-informed treatment. Although presentations of overt manifestations of dissociation symptoms may vary by culture, the 5-component model of dissociation as applied by the SCID-D interview yields diagnostic results that have proven to be culturally invariant, providing a universally applicable means for detecting underlying dissociative conditions. Somatic, meaning body pain, is common manifestations of underlying dissociative disorders. When patients with such symptoms are assessed with the SCID-D, often a more complex dissociative disorder will be detected, superseding the somatic symptom diagnosis that might be suggested by the ICD or the DSM. Establishing the patient's true dissociative condition facilitates treatment aimed at recovery, not just at reducing body pain symptoms. The SCID-D interview yields rich, clinically relevant information about a person's inner world and lived experience. This provides a framework for understanding an individual's sense of disconnection from their authentic feelings and needs. In addition to its diagnostic utility, the interview has been found to provide therapeutic benefits, both in accelerating the therapeutic relationship and eliciting material about a patient's previously hidden or misunderstood experiences in their inner world, especially when administered by a non-judgmental, empathic interviewer. Making space for the individual to develop a more coherent narrative about their dissociative experiences constitutes one of the interview's principal benefits. It should also be noted that the SCID-D offers therapeutic benefits precisely because it does not pathologize these normal human experiences. For this reason, the information elicited during the interview can be used during feedback and in therapy to validate, educate, and empower clients. So for making an accurate and formal diagnosis of dissociation, there is no better assessment instrument than the SCID-D. However, it is a bit challenging because it is a very long, complex interview format that usually takes somewhere between 3 to 4 hours to complete. It is nonetheless a valuable experience for the client and the counselor because the detailed, non-pathologizing discussion of dissociative symptoms it encourages. Many of the SCID-D diagnostic questions can be introduced separately to elicit information about dissociation bit by bit as therapy proceeds, if the counselor cannot do the entire interview, even if it's broken up into various 1-hour sessions with the client. So for example, if a counselor suspects that the client may be experiencing transient time loss, they could ask some of the following SCID-D questions. Have you ever felt you had memory problems? Ever had gaps, small or large, in your remembering of things? For example, I remember starting the project, but I don't remember finishing it. Is it ever hard to remember what you did yesterday or last week? Are there ever whole hours or days that seem to be missing or that you have difficulty accounting for? Have you ever found yourself having traveled somewhere without remembering how or why you went? So we've been talking up to this point about how do you screen for clients that may be impacted by disassociation after experiencing trauma. Then we've talked about how do you diagnose it, which I've given you one assessment that is diagnostic level, as well as an interview that's diagnostic level. But then it's like, okay, let's say you know that you've got somebody that has this issue. how are you going to work with them? And what kind of training do you need to work with them? So that's where we're transitioning now. This slide is, I'm attributing this to Heller and LaPierre's work, but honestly, there's just a tremendous amount of research um, that explains this. We talked about that trauma is stored in the body implicitly in the right side of the brain. And when things are stored implicitly, it moves from the bottom up. So it's stored in sensation, in the felt sense, in body experiences. That information then moves up into the limbic system and impacts affect and emotion. And then it moves up into the neocortex, where it's driving things like meaning, beliefs, judgments, identification, self-talk. So let's say we've got an adult, they're in treatment, they've had a flashback. Well, that flashback is coming from the implicit side of the brain, and there's a body experience and a felt sense and a sensation. And immediately, once that hits, that flashback then moves up and impacts the person's affective state and emotions. And then it reaches the neocortex, where then they may have, let's say, some really negative self-talk or meaning, beliefs, judgments. Things are moving forward. Um, so, top down information. And, basically from the point of conception, all you have is the implicit side of things. The explicit is housed on the left brain side, but remember, that's not really completely fully on board for many, many years. And we've got a split brain effect that's going on before age 12, where prior to age 12, everybody's really in right brain implicit, and the explicit's trying to come, the right or the left side is trying to come online, but it's not working very well. So the problem is that when we're working with people explicitly, so like you're doing CBT with somebody, well, you're working at the explicit level. You're doing EMDR, that's at the explicit level. You're doing DBT, that's at the explicit level. You're trying to teach somebody, you're trying to get somebody to slow down the thoughts that are coming to them. You're doing that all at the explicit level. The problem is that it is not impacting anything that's going on down in the implicit areas of the body, from the body experience, the felt sense, and the sensation. And so the vast majority of how counselors are trained to think about and to work with people is way up at the level of the neocortex. But the problem is that what's driving behavior is actually coming from the implicit side. Most people incorrectly believe that what they think to themselves, their actions, what drives their behavior, all of that stuff is coming primarily from the neocortex, from the left side, the explicit memory, but it's actually 80% of that is all coming from implicit. And there aren't words for that. So it can be harder to access, but this is why a lot of folks who have experienced major trauma or long-standing trauma, and especially the younger that it begins, they'll go through, DBT, EMDR, all these kinds of treatments, and they superficially might be doing a little bit better, but ultimately their life overall is still continuing to fall apart. And then they feel like a failure, and why isn't this working for me, and all that kind of a thing. And the problem is in the flow of information. So to understand how we get into a distress cycle, we've got to first comprehend how information flows top down and bottom up in the nervous system. So the term top down refers to how cognitive structures of the brain impact the emotional and instinctive systems of the body. Top down, our thoughts, judgments, and identifications affect how we feel and impact the nervous system's capacity for regulation. The term bottom up refers to how regulation in the nervous system impacts cognitions. Bottom up regulation, dysregulation in our nervous system affects our emotions and thoughts. So babies most often rely on bottom up perceptual mechanisms. When a child experiences early trauma, a distress cycle is set in motion that initially moves bottom up and later top down in a continuous self-reinforcing loop. Bottom up trauma creates nervous system dysregulation. When people experience trauma, they feel bad, and in children in particular, they think they're bad when they feel bad. So chronic bottom-up dysregulation and distress lead to negative identifications, beliefs, and judgments about the self. And these negative identifications, beliefs, and judgments in turn trigger more nervous system dysregulation, and a distress cycle is created. Bottom-up mechanisms are involuntary, most often unconscious, held in implicit memory, and related to the physical effects of the environmental stimuli upon the body. In contrast, top-down mechanisms can be voluntary, conscious, held in explicit memory, and pertain to how memory, motivational relevance, emotion, attention, and imagery shape perception. Top-down therapeutic approaches focus on the cortical functions of cognition. Bottom-up therapeutic approaches focus on the body, the felt sense, and the instinctive responses as they are mediated through the brainstem and move upward to impact the limbic and cortical areas of the brain. Continuous loops of information travel from the body to the brain and from the brain to the body. And similar loops of information move among cognitive, emotional, and instinctive structures within the brain. Now, this is specific to Heller and LaPierre's work. They have done a really nice job of mapping out what this distress cycle looks like. So we've got a caregiver that is misattuned and is creating some kind of abuse or neglect situation. And of course, the child's going to feel distress. And in reaction to that, the child will see themselves as bad because they'll feel bad. When young children, when they feel bad, they'll believe that they are bad. And shame begins there. Now, if the caregiver continues to be misattuned and create abuse and neglect in the child, that's going to cause despair to happen. And the child is going to disconnect from their core needs. And when they do that, and part of the core needs is the connection to the body. And then when they do that, it creates the loss of capacity for them to self-regulate. And then there's a lot of shame-based identifications. Well, that's going to feel miserable. So in order to compensate for that, there's going to be pride-based counter-identifications. And then that is going to cause increasing dysregulation. So this is the distress cycle that individuals who have experienced trauma, and especially when the trauma happened, the younger that they were growing up and the more often that that trauma happens, the more dysregulating that is going to be, and then the larger impact that's going to have over the person's life. Now, Heller and LaPierre also have created a great graphic about the healing cycle. In order to help trauma survivors, two things have to be going on. One is they have to have increasing capacity for somatic awareness. What does that mean? They have to have increasing capacity to be in touch with their body. The problem is that in order to survive the trauma at the time, they had to disassociate from their body. And this is why, if we've got trauma that happens from conception forward, the younger that's happening, the more often that it's happening, the more the person is going to detach from their body. The more they completely detach from their body, and that's survival in the moment, over the years, that is going to lead to an enormous amount of internal dysregulation, and it will lead to mental health concerns as well as physical health concerns. So what we have to be able to do as a counselor is we have to know how to work with some people, with people who've experienced trauma in their bodies, and we have to know appropriate ways to increase their connection to their body so they can discharge shock states, so they can begin to increase regulation and presence, and they can increase contact with their own body. It gives them greater capacity for self-regulation, which then helps them to understand the survival style that they've embodied that isn't really working for them that well anymore, but they don't know any other way of being. Then that helps them to inquire about that, to disidentify from shame and pride-based identifications, to reduce self-hatred, self-rejection, and self-judgment. Then they can reconnect with core needs and then restore connection and aliveness. But this is a long, 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 long process. But it's all based in increasing the capacity to connect with the body and to pay attention to the body and what the body is trying to tell them. And this is hard because it's going to be terrifying for somebody who's experienced a really significant trauma. How they survived was to completely detach from the body. Now, in order to heal, they're going to have to reattach to the body, but that's terrifying. So you have to know how to do that in a way where you're not going to set them off, how you can be healing and not provoking them. But the last thing these individuals need is to be doing EMDR or any kind of DBT or CBT or any of that stuff, because we've got to help them slowly be able to get back into the body to be able to release some of that implicit information that's been stored, and we can't get at that through talking about it. So it's a completely different way of working, and it's why most developmental trauma survivors don't recover as fully as they technically could, because they don't even know they're dissociating, but they don't know why they're dissociating. But even if they can figure out that they are dissociating, they it can be really terrifying to start to get in touch with their body unless they are working with somebody who knows how to do that with them in a safe way. So there's a couple of books that are just required if you want to help anybody who has dealt with trauma in any way, shape, or form, because this will, well, the book is titled Healing Developmental Trauma. Anybody who's experienced trauma is going to be helped by understanding this book, well, at least the counselor that's working with them. So Healing Developmental Trauma, it's by Doctors Heller and LaPierre. This book, the ISBN number here is for the book. There aren't that many of these books that it works out this way, but this book is also an audiobook, so you can actually get it as an audiobook. This is so foundational, though. I'd encourage you to have it as an audiobook as well as have a physical copy of the book. It's just worth that much. And while they give you a couple of the charts in there, a lot of the charts that they have in the book, they aren't giving it to you if you're listening to it, from the audiobook. But this one is worth, you've just got to, you have to have it, you've got to listen to it. This is just foundational. The second one that's foundational is Healing the Fragmented Selves of Trauma Survivors by Dr. Fisher. And, ironically enough, this is an incredible book, and it also is an audiobook. And like I said, often we don't have really good books like that that are also audiobooks. I have both. I'd encourage you to get both, but this is something else that um, if you are ever going to work with anybody of any age that has survived a trauma, this is just critically important information for you to have. So this is must reading as well. So now I'll talk about trainings because you're going to have training to do this, and sadly, it matters what you're trained in. It even matters who's doing the training. There have been so many times where I have worked with supposed experts, gone through their certification trainings, spent a lot of time and money only to figure out that they really didn't know um, how to truly do this work with trauma survivors, and um, it was really, not only did it waste a lot of time and money for me um, as a professional, but it also wasted a lot of time and money for me personally in terms of my own healing. So I've already talked about the fact that counselors, I don't care if you're seeing someone who has just been born, it's their first day of life, or it's their last day of life and they are 100 years old. Um, the implicit part of the self, that is on board the entire time. That is keeping a running track of everything that's going on. It doesn't make excuses about, oh, well, this person really didn't mean it and all that stuff. The implicit side of the body and memory, um, it knows it knows exactly what happened when it happened. It doesn't have words to put with it, but it knows. So to not have a certification training in somatic treatment as a counselor is, you will always, always, always be doing every client a serious injustice. So somatic trauma healing certification with Dr. Blakesley is awesome. It is fantastic. This woman knows what she's doing. Oh, and by the way, um, if you think that, oh, well, somatic body work will only apply in individual counseling, but I'm only going to see couples or I'm only going to see families, oh, you are so, so wrong. And in fact, that's a really good time to pull out um, somatic counseling work, is when you're working with more than one person in session. Um, the PESI product code for that, I've listed it here, CRS 002178. Um, around the holidays, and especially like right before Black Friday and then during the holidays, this training, while it's several $100s normally, many, many hundreds of dollars normally, um, this was on sale for $99 very, very recently. And to get this certification with somebody who is worthwhile to get the certification from, just incredible. I could not more highly recommend um, Dr. Blakesley, and really any training that she has, but certainly it's not like you can take, I mean, a certification training, it's much more robust, it's much more involved. Um, Taking something that's just a couple of hours here and there and thinking that you understand it and you've got it is not going to be where it's at. But just because we're talking about a certification training, you can wait for these magnificent sales and you can get this incredible training, which will help you and all of your clients. Um, and again, could not recommend this certification training more highly. So I've currently got a couple of recommendations in terms of getting trauma treatment training at a bare minimum. And this is incredible to do no matter what. Is Dr. Fisher's Integrative Trauma Treatment Masterclass. This is also through PESI. The product code is NRS 001337. This is also something that, at full price is going to be over $1,000. at least if, oh, well, if not, it's going to be pushing it. Um, but this was also one that, the last Black Friday and around the Christmas holidays, they had this also for $99, which is incredible. Um, so at a bare minimum, I would say the somatic certification training, as well as this um, particular trauma treatment training, that's just kind of at a minimum of what would be highly recommended to do. Um, Dr. Fisher really does understand how to work well therapeutically with individuals who have either complex PTSD or um, developmental trauma. She's just integrated all of this the best way possible. So that's why I would recommend this no matter what. So now this third item, this is actually a trauma certification training. Um, it's technically a complex trauma certification training. It's both levels 1 and level 2. This is again with Dr. Fisher. PESI product code AFC001292-08. This is something else that, around certainly the Black Friday, you can get this at a huge, huge, huge deep discount. I would encourage you to do this one too if you can afford it. Being able to have complex trauma certification training with her is incredible. The other one that I was talking about, the integrative trauma treatment masterclass, I still would recommend that even if you go through this one. And it can really be advantageous to have a complex trauma treatment certification training along with a somatic certification training as well. Um, I don't think it matters where you work or with what age group. There's just no way that going through these trainings will not help you in your work with clients as you move forward in your career. So for those of you who have held out and listened to this whole lecture, I really appreciate it. I do hope that it will help you to be able to help those that you see as a counselor as you move forward with your career. So again, thanks for listening. Take care and have an absolutely great day.